So my name is Dr. Doug Campbell. I'm an anaesthesia specialist from Auckland City Hospital. I'm going to talk to you about a project that I've been leading called NZDRISK, which is a non-cardiac surgical risk calculator applicable to adult surgical patients in New Zealand. Probably about 15 years ago, when I started in the anaesthesia clinic, I was having great difficulty explaining to patients what the risks were because I was having to use data from overseas that was often quite old and didn't really apply to the kind of patients I was dealing with here in New Zealand. One of the good things about NZDRISK is in New Zealand we have very large, high quality data sets, largely from the Ministry of Health, and researchers like me can access this data and use New Zealand data to produce a risk calculator like NZDRISK. NZDRISK is a multivariate risk model. All that means it's a mathematical model where you put in patient features like age, what sex they are, what operation they're having, and other features about the patient, and then you can develop a risk of a patient dying at 1 month or 1 year or 2 years after surgery. When a surgeon or an anaesthetist talks to a patient about risk prior to surgery, it's a balance of risk. The surgeon will have talked about the benefits of surgery, but many of our patients are becoming increasingly elderly and they come with a host of severe medical and surgical diseases that can add to the risk of having surgery. Most surgeons and anaesthetists are familiar with many risk calculators, and there's been a recent survey in the anesthesiology literature or anesthesiology journal, and here we see a table of some quite prominent overseas risk calculators. Some of these risk calculators are quite old, they're 20 or 30 years old. They're not applicable to all surgeries, and all of the risk calculators in that article are from overseas. None apply to New Zealand patients. NZDRISK was derived from a population of 360,000 patients, 2 years of all non-cardiac surgery in New Zealand patients, and it is easily large enough to be statistically accurate. On the left is the calibration plot for the surgical outcome risk tool, which is a high quality, well-validated risk tool based in the UK. The area under the receiver operating characteristic is 0.9 in a New Zealand population, which makes it sound like it's accurate. But if you look at that calibration plot, the calibration slope is 5 times the line of unity, which means there's a 5 times more risk being calculated by sort than in a New Zealand population. It is not accurate in a New Zealand population. On the right, we have the calibration plot for 1 month mortality for NZDRISK. It has an area under the receiver operating characteristic of 0.92, which demonstrates that it has excellent discrimination. But importantly, the calibration plot follows the line of unity very accurately, as you can see, which means the 1 month mortality statistical characteristics are the most accurate risk calculator we have for a New Zealand non-cardiac surgical risk population. It is highly accurate. And we can see the same holds true in the 1 year and 2 year model, and it is my belief that NZDRISK is the best validated non-cardiac surgical risk tool available to New Zealand clinicians and patients. The area under the receiver operating characteristic of 0.92 means we can discriminate from patients who are going to be dead at a month or survive for a month. And this is a very useful characteristic because it means when we categorise patients as low risk or intermediate risk or high risk, it does actually mean those bands capture those who get into trouble and those who do not. I've overlaid a green box here that is 80% of the patients in the validation set, where very few patients will be dead at a month if you have an NzRISK of less than 0.5%. And I would suggest to you, many of the patients who died in this low risk category might be background deaths from some of our elderly patients having low risk operations. Identifying low risk patients is very useful, and we are incorporating this into a process at Auckland City Hospital where low risk patients presenting to a surgeon at their booking visit can be fast tracked to surgery and not have repeat clinic visits because they're low risk and they really don't need additional workup. Well, now nzRISK is available. I'm using it in the clinic with patients. It's quick and easy to use either on a smartphone or on the computer on the desk. Patients find the output, the results very easy to understand, and shared decisions can be made using good information. You can access nzRISK on your smartphone or on your computer. Just plug in nzrisk.com and it'll come up and you can quickly calculate the risk for your patient.
I'm Dr. Martin Misher, a specialist anaesthetist at Auckland City Hospital and the developer of the nzRISK website. I'm currently working on the translation of the nzRISK tool into clinical practice by building it into a number of our clinical pathways to help optimise patient care. So this is the nzRISK website located at nzRISK.com. At the top of the screen we have some background information, and there's a link to the peer-reviewed article at the British Journal of Surgery. Skipping down the screen to the section where you make the calculation, there are some notes to the users on the left-hand side with an explanation of what the ASA score is, and just a note about the definition of malignancy. This is a very quick and simple tool requiring just 7 inputs. So here I've inputted the information for a 70-year-old female Māori patient who is having a hemicolectomy for bowel cancer. It is a matter of entering those. I then hit calculate and are presented with the output in 3 different formats, with percentages on the left-hand side, a text description in the middle, and an infographic on the right-hand side. As well as mortality at the 30-day point, clinicians are provided with information as to the death rate at 1 and 2 years, and this will help with the decision-making process.